You're listening to the RC Executive Lounge podcast, the show where healthcare revenue leaders share real-world strategies, hard-earned lessons, and bold ideas shaping the future of revenue cycle. The views expressed by guests are their own and do not constitute endorsement of any specific product or solution.
Hi, everyone. Welcome to another episode of Season 2 of the RC Executive Lounge podcast series. I'm your host, Praveen, and I'm really glad you're all joining us for this episode today. Today's episode is going to be really exciting. Why? Because we're welcoming a guest whose career spans health plans, consulting, system-wide revenue cycle leadership at one of the largest integrated health systems in the Southeast. Our guest is Christina Slemp, System Vice President of Revenue Cycle Financial Services at Chapel Hill, North Carolina-based UNC Health. Christina joined UNC Health in June of 2025 from Community Health Systems, where she served as the Vice President of Revenue Cycle for over 13 years. She brings more than 25 years of leadership experience across hospital systems, health plans, payer contracting, and health information technology. She holds a dual master's degree in healthcare administration and health informatics from the University of Missouri-Columbia and recently graduated with her doctorate of healthcare administration from Oklahoma State University. And most importantly, she's a very active member of the HFMA Revenue Cycle Executive Council. Personally, for me, what I find compelling is Christina's combination of operational depth and strategic clarity. Shortly after stepping into her role, she began guiding UNC Health patient finance through a major restructuring that consolidated professional and hospital billing with AI and automation central to a broader enterprise innovation strategy across the front, middle, and back of the revenue cycle. She has also been a very vocal advocate for using AI in the provider-payer dynamic, including how revenue cycle leaders can use data and analytics to, in her own words, make payers come to the table during contract negotiations. On the importance of communication in this work, Christina has offered a perspective that stands out. People get so data-driven that they think everyone understands data. Different audiences absorb information differently, and if we don't take the time to connect the dots for them, we risk losing impact. Our job is to make the data real, what it means, why it matters, and what action it should drive. We'll talk today about her journey into system-level leadership, change management work she has been involved with, and how she's thinking about AI and automation, the evolving provider-payer relationship, and the leadership lessons she has carried across more than 2 decades in healthcare. Now let's welcome Christina. Christina, welcome to the show, and most importantly, thank you so much for joining us today.
Thank you for having me.
Fantastic. Let's dive right in. Most organizations have claims denial management as a multi-year ongoing initiative. How does it work in your organization? And in general, given the breadth and depth of work to be done within claims denial management, how do you determine priorities for various line items in this program?
Yeah, well, I think when we talk about denials, it's intentional to be multi-year because payers are ever changing, the landscape's ever changing. There's always some sort of barrier in the way, but I think that really approaching denials from multi-dimensional lens, starting with prevention and prediction, are probably the two most important things that any organization could do. From a strategic level, we focus on those larger initiatives. Where are we seeing the biggest dollars, the biggest volume of denials, where we know that opportunity is most significant. But at the same time, how do we micro-target a particular physician not documenting a particular code that's coming through? So you have to have that multi-layer in there. And so we've recently implemented a 6 weeks cadence on that micro-targeted. So we have these multi-year large ones, Oz, I think everyone's dealing with Medneck and Oz, but on those micro-targeted, we're looking at like a 90-day look back, and we're looking at any spikes in a particular CARC or RARC code from a payer, and then we're going and we're diving in and we're root causing. And so we're kind of going old school, like we're using data, but then we know that those codes can mean a lot of different things. So we're going through and we have a subject matter expert root causing each of those. And then, and it's quick, 6 weeks is quick when you talk about implementing a solution. So we're root causing, and then we're coming and saying for a solution, it's X, Y, and Z. Then we're presenting that into an executive committee. And that executive committee has our clinical, it has our rev cycle, it has our financial, it has everyone from across our organization. And that's where you get that cross-functional support and making sure everyone has a vested interest in your denial prevention. I think at face value, everyone wants denial prevention to happen, but when it starts to impact their day to day, a lot of people don't always have the time because let's be honest, it's not just rev cycle. Everyone in healthcare is juggling all the balls in the air, trying not to make for sure something falls and hits the ground. So really trying to make this as easy as we can and get those micro targeted. So we started that. And every 6 weeks we're kicking off. So we've got phase 1 going, phase 2, phase 3, all simultaneously going and bringing those folks together. And so the goal would be that in 6 months we start to see some of those individual denials decrease. Now, are we going to see 2,000 denials decrease? Probably not. But when you think about rev cycle and how much a person can work in a day, it could take the place of 2 FTEs, right? And we have a hard enough time hiring our FTEs now. So that's 2 approaches. And then predictive, we're trying to use the AI automation RPA on the prediction piece. And when we don't get it all there, we want to make for sure that we have fail safes on the back end and the patient finance. And so that's where that AI comes in on either producing the appeal for you, but I think where a lot of people miss the mark is where's the RPA in conjunction with that? Because that's really where you're going to get your maximum benefit is when you have the AI and the RPA together, and that's best practice for us. And so a great example that I've seen organizations do this in is have the automatic appeal for the EM downgrades, whether they come through as a true denial or an underpayment, and automatically do that appeal letter, but then put the RPA or robot agent on there to automatically upload it for us. And so now we're getting to appeal things that we wouldn't have gotten to do a year ago, 2 years ago in some of our systems. And so I think those are great analogies of what we can do when we're looking at denials and trying to combat them.
Plenty of takeaways in what you said. The 3 that stood out to me were 1, 6-week sprints, 2, having RPA and automation together, but RPA and AI together, but most importantly, using data to drive a lot of the decisions within the 6-week sprints. That's a great segue to the next question. You have looked at data in multiple organizations for claims denial management. Based on everything you've seen from data across organizations, what have been some of the top reasons driving denials? I mean, you get quotes from payers across various different categories. Repeatedly across organizations, what are some of the themes in terms of priorities or reasons that are driving denials?
I think ones that we really can help at the beginning is eligibility, right? Like putting all the tools that we can to support our teams at the front desk. We know there's high turnover there, training's hard, but however we can make it the easiest for front end to get those eligibility, it's the number one impact that we can make. Secondly, is surgeries, right? What we ought isn't what we did. So making for sure that we have a process in place to identify that quickly, because a lot of times the payers only give us 24 hours, right, to update that authorization. And the third one's really a long term, and I'm really not for sure the solution, but agreeing on what is medical necessity at the time, right? Agreeing on what the decisions are up front, because once it makes it to the back end and the patient finance side, it's so much more difficult. So I think payers and providers are going to have to come together, but that's a more long-term strategic goal. But internally, any organization, those are 2 very easy ones that you can tackle. I say easy relatively.
Absolutely, yeah. Every organization is different. Every payer is different. Completely understand. In your experience, what has been the range of denials that I've seen across organizations? And this is not specific to your organization. I mean, you talk to other executives in executive council as well. What have you observed in terms of the range of denial rates across organizations? And being an executive who have seen multiple organizations and solved this multiple times, what do you think is a realistic target to bring down denial rate for any organization who could be using something like agenticai automation and operational changes working in tandem?
Gosh, again, I think it's relative to where your baseline started, right? So if you have a high denial rate, you obviously have a bigger impact to make. When your denial rate is already low, that makes it more difficult to decrease. Our organization is relatively low to begin with, so it's probably not going to have as big as bang as an organization that maybe I previously would have been in, where denials were a lot higher. So for us, though, as we decide what to tackle, it's the impact. It's not just money, it's how much time does it take to get it done.
Yeah.
Right. So it may not be, it may be low volume but high dollar, or it could be that we're not going to tackle it now because it's too much manual process. We're going to try to do as much education as we can, but we're not quite to the point to implement AI or RPA or things like that. So I think it becomes a multi-strategy there. And I think it's difficult to say just because every organization is different from their baseline.
Makes sense. A follow-up question here, and you mentioned that the impact is going to vary based on what is your baseline. Totally understand. For a program like this, given that it's a multi-year program, then what do success targets look like in a given year? Of course, it depends on maturity of the organization and what is the baseline. But what do realistic success targets look like? And even across multiple years, when do you know that you're close to achieving your vision for this program? Or in other words, the incremental ROI is being minimal by pouring more into this program?
Yeah, so I think that that's very, I'm going to say dicey for lack of a better word. I think because whatever we started in our strategies change, right? The vision changes. So, for example, we could say that we want to decrease preventable denials by 30%. At the end of the day, our write-off may not ever change, but we're trying to get the operational touches out of the way so that we're not touching them. We could, in fact, decrease in, let's say, authorizations by 30%. But now we have a payer with bad behavior that increased our denials over here. So our strategy changes and our goals change and our vision changes. So I don't know that a 3-year strategy to say that you're going to decrease your denials by 20% or 10% or whatever you choose in your organization is always realistic, because the landscape's ever changing. The providers are changing, policies. So if we really want to get into policies and how those impact our denials, getting a denial on itemized statements when we're getting 90% of them paid. And so I think those are things that change our landscape every day. So the vision that we had a year ago when I started is still the same vision, but there's a lot more A, B, C, D, E's that came into it. So we may have met our vision in certain areas that we targeted, but now we have new ones that came up that become our vision again. So we may be at baseline, even though we did all this great stuff and we met some amazing metrics, we may still be at baseline, but that doesn't mean that our strategies were not successful.
That totally makes sense. Thanks, Christina. That's a good segue to the next segment. Let's take a short break here. When we come back, we're going to discuss with Christina on an important claims denial management initiative that she had led her organizations through. Let's come back in a few minutes and talk more about the initiative.
When care feels out of reach, patients walk away. Hospitals are left with denied claims and money they cannot collect. RCHQ's agentic AI cuts claim denials and helps patients set up payment plans that fit their budget, while connecting them to assistance programs like Charity Care and Medicare. Seamlessly integrates with your existing RCM systems with no coding required. Empower patients, protect revenue, increase cash flow. RCHQ, every patient's trusted AI financial assistant.
Welcome back. Christina, let's dive into a recent claims denial management initiative that you led your organization through. Let's maybe start with what challenge you are solving for.
Yeah, I think the challenge is money at the end of the day, right? Cash is king for most organizations. That's how we keep the doors open. That's how we buy the equipment. That's how we care for our patients. So how do we keep more money in, regardless whether it is a true denial that comes through on a remit or an underpayment, which I think we're calling those denials that aren't really denials because they don't come through, and trying to identify them. So for us, it was trying to identify some of the underpayments that don't come through as denials. So E&M levels are a great one. Some payers remit them as a denial, some don't. DRG downgrades that just come through and you get the lower payment. So I think denials have really changed in what a definition of denial is at the end of the day. And I think underpayments have become part of that. So what we found in not just our organization, but I think all organizations, is people love to work in silos, right? You have those personalities love to own something and they're really great at owning that one thing, but they don't venture outside of their vertical. And when you don't do that, then we're not fixing some of the root issues, right? We may have a great process on patient finance side that fixes it, but we never fix the root issue at the beginning. And so I kind of talked about our denial initiative that we started recently, and have done this in the past too, but really getting clinical people on board and getting it resolved and the root causes resolved at the beginning are really where your impact is in that. And so how do we do that? It's networking, right? Relationships are everything. So coming into an organization, I'm going to say I'm still new. I've only been there a year, so I think, get to play the new card. But I think coming in and trying to get people to believe in what you believe in and understand it in a way. So we said in the very beginning, using data to get people to understand. And that's really key is, man, I can throw data all day at them, but if they don't understand where it impacts them or how they impact the data, it doesn't do me any good, you know? And so really getting to my team to understand, telling a story. It's not about data. It's about telling the story of what it has to say and how it impacts them. And, you know, if we're trying to get a clinician to change the way they document it, and we've done a ton of one-on-one meetings like that with different groups within the organization. And that sounds very probably daunting because people are like, oh, I don't have time. But if you don't get the core set, it doesn't do you any good. You're going to maybe make some initial impact, but long term, people are not going to be engaged.
Now, in this process, once you looked at the data, were there like a specific type of problem that you picked for this initiative?
It goes back to that, what was the outlier? You know, those short things of like what was the outlier? So do we need to meet with pharmacy department? Do we need to change the way Epic changes and the way Epic fires? Those are just some of the things that we've been working on through this initiative, and it tackles other denials. So the particular denial or micro denial that we were working on, it actually spans across other denials that may not have hit. But because we fixed it here, we fixed it in the future for other denials that follow that same process and pattern.
Makes sense. And you talked about the 6-week sprints where these kind of initiatives get implemented. For these 6-week sprints, how often has it been purely in-house versus how often have you relied on a vendor? And in general, can you walk our audience through your framework of how you decide on in-house versus vendor?
Sure. So previous organization, we looking to partner. I think everyone's looking at AI, but I think everyone's utilizing AI in some frame of mind to help us and partner. And what does that look like? What do we do really well internally? What can I help support in that? So previous organization, we built it internally after meeting with lots of vendors. We had the bandwidth. Something to keep in mind though, when you look at that is, how do you have the staffing to keep up with the market? Do you have the staffing to keep up with the changes? And if you don't, it's probably a great idea to find a great partner. And what do you like in a great partner? Somebody that believes in your vision, somebody that is going to be flexible and understand what you want and what you need to say. And we've done that with our partner in the denial space. What we didn't solve for in the beginning was the RPA. So I can't say that enough, is like AI is great, RPA is great, but when you put them together, like it's going to give you the best possible. Now, the other thing that we've run into, and I'm sure many organizations do, is the trust value once you go to AI, you know, trusting that the AI is right. So if whatever you put into AI is what you're going to get out of AI. So if
Yeah.
you have a bad process, it doesn't matter how good your vendor is, but if we fed them a bad process, it's going to be bad coming out of the gate. So I think it's very, very important that people understand that foundation is important. So when you're evaluating, whether it's a vendor or a process, you've got to make sure the process is where it needs to be first, then that vendor, or you're setting yourself and your vendor up to fail. But yes, looking for a vendor that's going to believe in what we believe in, support what we believe in, and make changes as needed and be flexible with us.
Makes sense. And let's talk about implementation. As your team went through implementation, were there any pitfalls, surprises, or lessons you all learned that you would like to share? Also, we've heard in some conversations that specifically for claims denial management, the EMR or EHR you're working with could make a big difference in what you can realistically implement, especially when you're looking at agenticai solutions. Maybe can you talk a little bit about what pitfalls or surprises you came across during this process?
I don't think it was necessarily pitfall or surprises. I think trying to solve for 100%, right? I think is sometimes the enemy, right? Great is the enemy of good.
Yeah.
And so you have to really look at that risk reward piece. Obviously, compliance is number one, right? Regulatory is number one. But I think falling into the pitfall of thinking that we have to have it 100%. Because when you think about manual and you and I touching something, if we were to write an appeal, there's still things that aren't 100%, right? We do it to the best of our ability. And so I think just ensuring that you have that standardization. I think the other pitfall organizations, not necessarily where I'm at now, but can fall into is governance. They want a governance too much. And governance shouldn't be a bad word. I think sometimes operationally, operational teams sometimes feel like governance is a bad word, and governance should never be a bad word. Governance should be like, this is to make sure that we're doing it compliantly, we're doing it correctly, and that we're doing it safely, and that at the end, standardization will help us. It's a lot to go through in the beginning, but I do think a lot of operationally, it's like, why can't we just do A, B, and C? It seems so simple in an operator's mind. But the governance is really important when we talk AI. These are people, these are patients' data, this is processes, these are claims going out the door,
Yep.
And patients at the end of the day. So although it's not clinical in the rev cycle, I think it's just as important that we keep that safe.
Yeah. And governance is one of those aspects where the more time you put up front, the less you have to worry during the time of an audit. Otherwise, it becomes a bit of a nightmare during an audit, right? So completely agree with you on that.
Absolutely.
So for this kind of a program, what has been the measurable impact that you've seen either in this organization or in previous organizations? And in general, maybe can you talk a little bit about how do you track success? Like, it's obviously not just one metric. There'll be multiple metrics that you and your team will be tracking. Anything you can share would be really helpful here.
Yeah, I think on the front end in our patient experience, we're seeing early wins and shifting from a reactive to proactive. And I think organizations that do not shift to proactive will be the ones that are struggling in 5 years. And if we look back the last 20 years, RevCycle's always been reactive. We've always been the fixer. We've always been the folks that got it back out the door. But again, relationships are important. I cannot point that out, like getting it done. But I think seeing those wins up front, and I think when people start to see the wins and they start to see the importance, that gives them more support. They're willing to support it more. They see the wins, they get excited about it. And we're also seeing improvements in productivity, the less manual work. When we talk about AI and RPA in physician billing, that's volumes, right? It's not always dollars are there, but the volumes are what kill our teams. And so I know coming in one of our projects, teams are always worried about losing their jobs. Always get asked, how do you get people to not worry about that? And it's so we literally spent an entire town hall talking about, here's everything we're not touching. Here's everything we had to adjust off in the last year because we couldn't get to it. This is meant to support you and help you. And so those productivity improvements were a game changer for some of our teams, as I've worked with AI in the past. So I think that's really important to the way that we phrase it, the way we talk about it, the way that we implement it is always important in regard to change management. And then we do track a few things, denial rates, overturn rates. More importantly, are we reducing avoidable denials and rework in the life cycle of a claim? And that's really the goal. Our ultimate write-off may not change, but if we're reducing the touches and the productivity and what we manually have to touch, that's a win in and of itself. And I think some people forget that sometimes, is that it's not always about the end number. Your number could always be the same, but if you went from 10 touches to 2 touches to get it, it's still a win.
It is. It definitely is. Some very powerful insights. Thanks, Christina. With that, let's take a short break. When we come back, we're going to hear from Christina about her thoughts on up and coming technologies in the area of claims denial management. Please stay tuned.
1 in 5 hospital claims is denied. Behind every denial is a patient delaying care and a provider losing cash. With RCHQ's agenticai, fewer denials mean faster reimbursement. Patients get payment plans that fit their budget and access to programs like charity care and Medicare. No coding required to make RCHQ work with systems you already use. With RCHQ, you see an instant increase in cash flow.
Welcome back. Let's dive right into up-and-coming technologies. Now, when we go to HIMSS, HFMA, MGMA, or any healthcare event for that matter, agenticai is the buzzword, right? An executive at your level, what role do you see agenticai playing within claims denial management when you look ahead the next 12 months versus the next 3 years and the next 5 years?
Yeah, I think if you look back the last couple of years, it's been very task oriented in regard to AI and RPA. And I think that's where we are going to have to go with pieces of the process. We're going to have to connect all the dots. Like, how do we use AI in every vertical from clinical all the way to the end and interconnect it? And I think organizations that do that are going to be the ones that are going to be thriving in regard to AI. And we don't want to forget governance. Like you said, governance on the front end and making sure it's strong will help us do that. I also think some of our biggest opportunities are on the front end and making predictive. That's what we are really looking toward right now. Like, we have all of these other structures in place for standardization and making for sure that we are consistent. But now I want to know, like, what do we think's going to deny, not what's going to deny, and fix it before it goes out. And so we can put claim edits in. Those have always been there, but predictability of what's going to happen based on payer behavior and the way that our claims have worked over the last 6 to 12 months. So it's really less about replacing people, as I talked about, but more about giving teams a really intelligent partner to say, let me help you work smarter and stay ahead of the problem so that you're not the hamster on the hamster wheel and that you're not getting frustrated. I hear so many times when I round with teams, like, the payers, if they would, or front end, if they would just register it right. And it's like, at the end of the day, there's always going to be an issue, but giving people the tools to feel like that AI is a really good partner, I think is going to be a huge win in healthcare. And I really see in 5 years, it's going to be where we were in automation 10 years ago to now. It's going to be just part of our normal day to day. But I really do think for a lot of people, it's scary, the thought of it and what it can do. And there's still a lot of people that have not embraced it.
Makes sense. And you talked about data and metrics at the beginning of the show, and you brought some very interesting opportunities of using agenticai in claims management in your last response. Combining the two together, there are going to be some that are incremental in nature. There are going to be some that are like 2x, 3x, 5x in terms of impact. So are there areas within claims denial management where you think AI can truly change the nature of the game, not just incremental improvements, but really 2x, 3x improvements in terms of impact?
I think so. When we talk about prevention, when I talked about like systems that have AI as a platform instead of just one vertical, think about clinically. We have ambient listening. So if I have ambient listening and I can trigger a documentation that's needed to get an auth, then therefore that auth comes through and it's approved and nobody has to touch it after that. Like, what an amazing thing that is, right? And I think the more people can see that in place, those are going to be the 5 times incremental values that we have. And nobody's going to change really how they do their business. Yeah. It's supposed to feel complementary, right? This isn't supposed to be daunting. This isn't supposed to make people have extra steps. This is really supposed to make it feel like like I said, a great partner, a great technology partner, and a support system for that. So I think where we can do that and have good strategies, regardless whether it's through OS or eligibility, or like I said, the ambient listening or on the back end. Wouldn't it be great to have some AI platform in 5 years that we really had to touch 20% less of our claims?
Makes sense.
Uh, uh,
Fantastic.
yeah.
That totally makes sense. And with respect to claims denial management, outside of agentic AI in general, are you or your team members exploring other technologies as it is applicable to claims denial management?
Do you have an example?
I think ambient AI is one, obviously, that you talked about, similar to ambient AI. And when you look at the complete claims denial management stack, there are like so many steps, credentialing and on and on. Are there aspects of various parts of the claims denial management problem that could be solved differently in addition to agentic AI, maybe another technology or a completely different technology than agentic AI?
I mean, I'm going to focus on agentic AI again, but I think where we haven't fully explored, everyone went to AI denials, right? Like everyone's like, one, it takes so long to go through all the records, and it takes so long to connect all the dots. And are we going to use Milliman or Interqual? Like, what are we going to use? So that took a lot, but I think where we haven't quite explored yet is AI and policies, and coming up and going out to the payers and saying this policy and then taking our data from 6 to 12 months. And I know there's technology out there that's doing it through AI. We're in the beginning stages of evaluating that, but it's going back and looking and saying, okay, for billing, this particular policy is going to cost you 600,000 if you don't
Yeah.
change your billing practices, or for coding, if you don't, here's the impact. And I think many organizations are still have 2 or 3 policy analysts that are trying to take the policy and then trying to use data analytics to come and say what the impact is. But gosh, technology can do that for us now. And so that's where I think that we should be going into that. And it's still AI driven. In 5 years, we might have another hot topic other than AI. Like I said, 10 years ago was RPA. Now we're into AI. But I still think that's what we're going to be focusing on in many organizations in the next 5 years.
Christina, the example you came up with was very interesting, specifically for me, and I'm sure for our audience as well, for the one reason that we have heard this complaint that when a payer changes the policy, oftentimes the organization is so overwhelmed that they're not paying attention to that policy for at least 3 to 6 months after it has changed. What happens is they've lost a lot of money by then. And once all that lost money accumulates, then they start paying attention to it. And they are so shocked about how much this little policy change has had an impact on their RCM metrics. So your example hits the mark on target, I'm sure, for me and for our audience. So thank you for bringing that up. Again, let's take a short break. This is a good segue into the next section. When we come back, we're going to be talking about leadership challenges and navigating an organization through change management in the complex area of claims management. Stay tuned. We'll be right back.
Every denied claim is money left on the table. Every missed payment is cash flow you may never see again. RCHQ utilizes agentic AI to lower denials, set up families with affordable payment plans, and connect patients to affordability assistance programs like Charity Care. Lower denials, expand affordability, and strengthen cash flow. RCHQ makes it possible with no coding required. Visit rchq.com today.
Welcome back, everyone. We are in the last segment of this episode, which is leadership challenges. Christina, before we jump into leadership challenges, maybe a question around metrics. Is there a very specific claims-related metric, or maybe 2 or 3 metrics that you and your immediate leadership team obsess over every day? The first one you look at every morning.
Well, cash is always first, but then that's a bigger issue, right? You have to determine what goes into that. So for me, I don't know, every organization calls it something different, but discharge not final bill. Anything that's holding that's not going out the door really gives you a pulse on what departments it's holding for, where you need to push the button a little further. And if you don't get that quickly, it can really get out of hand really, really quick. And so we've seen increases across healthcare when people are out, people are on vacation. We don't have somebody covering for us. We have a 3-day holiday, all of those things. So it's very quickly that we have to monitor that to make for sure that we're getting those claims out the door, um, to get the money back in the door. And that's probably the number one thing I look at. There's other things. We have 4 or 5 things every day, but that's probably the biggest one that encompasses being able to put and identify if there's an issue somewhere.
Makes sense. And you've led multiple organizations through claims management challenges. What are some of the biggest challenges faced by organizations who are looking to bring step function improvement in reducing denials?
Oh, that's a great question. I think a lot of times they feel like it's people saying that we don't have enough people, we don't have enough resources, but it's really trying to communication, change management's communication, whether you are making an org chart change, whether or structure change, whether claims change, where you're trying to tackle I'm going to go back. It's all about relationships and making for sure that people feel comfortable enough to say things and to communicate when things are not going correctly, to help look for that goal and get to that goal.
Makes sense. And almost every RCM leader we've talked to have touched upon this topic in some form or the other, which is there is a bit of a tension between the technology team and the operations team. And the way it pans out is the operations team always has a bunch of requests to be implemented so that their life is made easy. And then the technology team obviously wants to implement innovations. These are risky bets that take time, but these can potentially bring step function change. Now, the operations request may or may not be as innovative, but they are the need of the hour to keep things moving. So you can see this conflict in 2 different ways, right? It's either quick needs of operations team versus innovation from technology team, or short term versus long term. How are you look at it? This is a bit of a tension that every RCM leader has to navigate through. How do you navigate this particular tension in your organization, and how do you build momentum for change when implementing claims related changes by keeping these 2 teams in mind?
Yeah, so I'm not going to say we figured it all out, but I've come from organizations where that relationship wasn't there, right? We worked in 2 very much different silos, and I think that happens in a lot of organizations, hence to the point you made about tension. I will say currently, we have a great relationship, and I think what's been so important as we've moved our verticals to front, middle, back at current organization is that we move together as a team at our level. And so we have dedicated resources. That's not always the case in systems to revenuecycle, which makes a huge difference. So in that, there's only 3 of us that have to determine where our priorities are versus an entire organization because we have those dedicated resources. But I think we're looking again, just like you would anything, what's the impact? How long does it take to get to the finish line? And so sometimes the bigger impacts that take longer may take a backseat to some of the quick fixes that we can put in or the quick things, and I think we have to come together as a leadership team. But there comes trust with that. Like I have to have trust in my peers. I have to have trust in my ISD, my information team, to make for sure that we all have the same goal in mind. And so I'm not going to say that we always agree because I don't think that ever happens, but I do think that we have a pretty good pulse together of what our end goal is. And again, I think I've harped this whole podcast on relationships, and I think trust and relationships are the key to being able to make great moves together as a team and not work in silos.
Makes sense. And as a leader who has navigated claims denial management challenges in multiple organizations, if there is one piece of advice that you could give to another RCM leader or maybe a CFO tackling denials management challenges in their organizations, irrespective of their baseline, what would it be?
I think that obviously I'm a huge proponent of using data to tell your story and to be really clear on priorities and why you want something and why it's important. And I also think that there should be that checklist. What's the priority? What's the impact? What's the productivity impact? It's not always financial, right? Like it's not always productivity either. But I want to make for sure that we are not implementing technology for the sake of implementing the new shiny toy.
Yeah.
I will give an example in my past career at a previous organization. It wasn't AI, but they wanted to automate something, and the cost of automation was more than the FTE that was costing me to do it. And it's like, I don't want to pay this because you're costing me more. And I think sometimes people lose sight. So making for sure that as we move forward, that we have that vision, we have the same vision. And if that means that we have to have a standard checklist, that's okay to guide us. It goes back to governance. Like if you have the governance of what's going to guide us in the beginning, it's not a bad word. It helps keep us focused on what we need to do and where we're going. And if we make every decision based on that, this is Christina's guesstimate. I have no data to back this up, but I feel like that we could probably get 90% agreement on most things when we use that as a guide.
That totally makes sense. One last question before we close the episode. Is there a recent book, a podcast, or a framework that has significantly influenced your leadership thinking in the last 2 years, especially when you look at the unique challenges you face as a leader in the claims denial management area? Has there been aspects from any of these sources that changed the way you approach leadership or change management for claims management?
Yeah, I think one is younger Christina probably worked harder to try to get things done. And I think that is taking a step back. When we talk about books, I think everyone should read this book. I don't care if you're a man or woman, but Likeable Badass is really focused on women. But what it really enforces is the balance between being empathetic, but building the trust. And also that you can be clear and decisive and willing to push for change, but also be empathetic and supportive at the same time. And I think sometimes we forget that in our roles, regardless what role we're in. If we're in leadership, we forget that we can be clear, we can be concise, we can be accountable. And I found that really relevant in the last year coming to a new organization. I came from an organization that I was at for a very long time. I'd built my team. They would jump off a cliff with me if I told them. They know that the parachute's going to open before we hit the ground. Knew I wasn't necessarily expecting or had forgotten how hard that is because I'd been at the other organization so long. So I found books on influence, and I think people really need to take heart as to influence. And I think I've said this the whole podcast too, is relationships matter, and that influence matters, that trust matters. And so books like that, I think, to help us better understand how to gain that and build that trust and understand people are going to help us be more successful in the future. And that sounds very soft, I know. But again, it's okay to be accountable. It's okay to be direct. It's okay to do all of these things, but we also have to be empathetic. We also have to use guidelines to get us to that end goal. And that book is probably the most recent one that I've read that felt like that really gave that, whether you're a man or a woman.
I'm super excited because we are closing the episode with what is arguably one of the most powerful insights of this episode. So thank you so much for closing with that thought. And of course, needless to say that this episode has had so many wonderful, deep insights on claims denial management. I know our listeners, our audience will be walking away with a lot of lessons on claims denial management. Christina, thank you for joining the show today. And hopefully we can have you again in the show sometime in the future. Thanks, Christina.
Yeah, thank you so much for having me. I think closing out with just the one thought, at the end of the day, change doesn't stick because we tell people to, it does because people trust us. And so the whole episode is about building trust if you want to change anything.
Again, very powerful insight. Thanks, Christina. Thanks for joining us today.
Okay, thank you.
You're listening to the RC Executive Lounge podcast, the show where healthcare revenue leaders share real-world strategies, hard-earned lessons, and bold ideas shaping the future of revenue cycle. The views expressed by guests are their own and do not constitute endorsement of any specific product or solution.